The intricacies of KRAS, a deep dive. Welcome, everyone, to today's episode where we unravel the complex world of KRAS, a topic at the crossroads of biochemistry, oncology, and cutting-edge therapeutics. Whether you are a student, a researcher, or just an inquisitive mind, this conversation will bring clarity to one of the most influential molecules in cancer biology. Introduction to KRAS. Let's begin with an overview. KRAS, which stands for Kirsten rat sarcoma viral oncogene homolog, belongs to the larger RAS-GT posse superfamily. This family also includes HRAS and NRAS. KRAS acts as a molecular switch within the cell, cycling between two states: an active state when bound to guanosine triphosphate and an inactive state when bound to guanosine diphosphate. Through this molecular toggling, KRAS regulates crucial cellular events such as growth, survival, and differentiation, primarily through signaling pathways like the mitogen-activated protein kinase and extracellular signal-regulated kinase pathway, the phosphoinositide 3 kinase and protein kinase B pathway, and the RAL-guanine nucleotide exchange factor pathway. KRAS and its role in cancer. Now, let us shift our focus to how KRAS is implicated in cancer. Certain mutations in the KRAS gene, particularly at positions such as glycine 12 and glutamine 61, lead to its constant activation. The most frequent are the G12D, G12V, and G12C mutations, which collectively account for about 80% of KRAS mutations observed in patients. These mutations are highly prevalent in several cancers. Approximately 90% of pancreatic ductal adenocarcinoma cases, 40% of colorectal cancers, and 30% of non-small cell lung cancers are driven by mutated KRAS. But what happens when KRAS is locked in this permanently active state? It leads to unrelenting cell growth signals, a phenomenon that underpins the uncontrolled proliferation characteristic of cancer. Additionally, KRAS mutations rewire cellular metabolism, increasing reliance on glycolysis, a process often called the Warburg effect, and glutamine metabolism. These changes support the energy and biosynthetic needs of rapidly dividing cancer cells. Moreover, mutant KRAS can suppress the immune response by reducing T-cell infiltration into tumors, often by upregulating programmed death ligand 1. Overcoming the undruggable KRAS. For decades, KRAS was deemed undruggable. Its surface is smooth, offering limited binding sites for inhibitors, and it binds guanosine triphosphate extremely tightly, making it a challenging pharmacological target. However, recent scientific advances have shifted this paradigm. Notably, researchers have developed drugs specifically targeting the G12C mutant form of KRAS. Two such agents, sotorasib and adagrasib, have reached clinical use. Sotorasib became the first KRAS inhibitor approved by the United States Food and Drug Administration, specifically for non-small cell lung cancer. Adagrasib, which can also reach the central nervous system, is active against metastatic disease. These drugs work by trapping the mutant KRAS protein in its inactive state. Furthermore, combining KRAS inhibitors with other treatments, such as mitogen-activated protein kinase inhibitors or immunotherapies like anti-programmed cell death protein 1 antibodies, can enhance outcomes and potentially overcome resistance. Other innovative strategies are also emerging, including targeted protein degradation techniques called proteolysis targeting chimeras and messenger ribonucleic acid vaccines designed to stimulate the immune system against KRAS-driven tumors. Clinical and diagnostic implications. Why does this matter in clinical practice? KRAS mutations not only drive cancer but are also important markers for prognosis and therapy selection. For instance, the presence of KRAS mutations can predict resistance to drugs targeting the epidermal growth factor receptor, especially in colorectal cancer. In pancreatic and lung cancers, KRAS mutations are associated with poorer outcomes. Diagnostic tools such as liquid biopsies can detect KRAS mutations in circulating tumor DNA, helping guide treatment decisions. Other techniques include immunohistochemistry and RNA sequencing for mutation profiling. Key diseases associated with KRAS. Several diseases are closely linked to specific KRAS mutations, each with distinct prevalence and clinical implications. In pancreatic cancer, KRAS mutations such as G12D, G12V, and G12R occur in about 90% of cases, making this genetic alteration a hallmark of the disease. These mutations contribute to the cancer's aggressive nature and resistance to conventional therapies. In colorectal cancer, approximately 40% of cases harbor KRAS mutations, most commonly G12D and G12V. The presence of these mutations is clinically significant because it predicts resistance to drugs that target the epidermal growth factor receptor, impacting treatment choices. In lung adenocarcinoma, about 30% of cases exhibit KRAS mutations, notably the G12C variant. This has opened the door for targeted therapies such as sotorasib and adagrasib, which specifically inhibit the mutant protein. Beyond cancer, germline KRAS mutations are also associated with developmental disorders like Noonan syndrome, where they contribute to a range of clinical symptoms. Together, these examples underscore the pivotal role of KRAS in various diseases and their outcomes. Segment 6. The road ahead. The future promises even broader horizons. Scientists are working on inhibitors that target multiple KRAS mutants, exploring synthetic lethality through combination therapies, and finding ways to modify the tumor microenvironment for better treatment response, especially in pancreatic cancer. In summary, KRAS stands as a central player in cancer biology, orchestrating growth signaling, metabolic adaptation, and resistance to therapy. Its story is one of challenge and hope, a reminder that even the most elusive targets can yield to persistent scientific innovation. Thank you for joining us on this deep dive into KRAS. If you found this episode enlightening, be sure to subscribe, leave a comment, and stay tuned for more explorations on the Everything Surgery podcast. Dissect the extraordinary.